I'm going to give you a brief overview of Chapter 26 in your Giddens book on mobility. So we're going to go through and I'm going to hit on the key points that you need to focus on when you're studying. You need to be able to define mobility, and basically it's the state of or quality of being mobile or movable. There's a few other terms that you're going to see stated in your book and on your information sheet that talks about what your requirements are for this particular section. And some other terms are terms of immobility, which is a term that you'll see us use interchangeably with mobility versus immobility, because we are assessing the patient to see if they are immobile in some way or another. It's the inability to move. And then you have disuse syndrome. It's predictive adverse effects on the body's tissues and function. And then deconditioned is a loss of physical fitness. And basically what occurs is if we don't use our bodies, what happens? And this is a question that I want you to ponder, because I'm going to bring this question up again in class. If we don't use our bodies, what happens to it? This next slide, what I want you to get from this is looking at the scope of the concept. Is when we as nurses assess mobility on a patient, we're assessing, maybe they just have a pinky finger that they can't move. That means that pinky finger is having immobility issues or is immobile. It can go, with mobility, it can go across the spectrum from minor problems with immobility to major, not being able to walk, not being able to turn themselves, pick themselves up. Like, for example, somebody that's a quadriplegic. So think about those things. Review of the musculoskeletal system. I'm not going to go back over anatomy and physiology. You have had that, and you're taking patho right now. So just remember, with muscles, bones, joints, the neurological system, which involves the brain and the nerves, that all of these things interconnect. And if we have problems with joints, then we're going to also have problems with movement within the muscles and things like that. So we could go back and have some problems with deterioration and deconditioning. Risk factors is important. You're going to see with everything that we look at throughout your program, looking at risk factors is a part of our job. As nurses, we do a lot of health promotion and teaching, and if we can identify risk factors, then maybe we can teach somebody and they will reduce, hopefully learn something from us and make a change in their life. So with risk factors, we got to look at traumatic injury, brain, spinal cord, bones, and joints. Somebody has in a motor vehicle accident and has a brain a brain disorder from that, where they fracture their skull and it's done some damage. They're going to take some time to get back up into a mobile state and get back to their optimal level of functioning. Also, neurological conditions. People that have had strokes will have problems with mobility. People with multiple sclerosis, things like that. With some other ones, ALS, which is Lou Gehrig's disease, gradually have those conditions that take over the brain and cause problems in the brain, which then inadvertently reduces the mobility and the function of the musculoskeletal system. Chronic conditions, cardiovascular disease. People with pulmonary conditions have reduced mobility because their bodies are so fatigued and tired due to the disease process. So you're going to see a lot of patients that if they have cardiac events, such as coronary artery bypass grafts, they go into cardiac rehab afterwards to be able to build that system back up. Also, there's other things that can reduce mobility would be end-of-life disease processes such as cancer and dementia. Dementia, you'll see a gradual loss of mobility. These patients usually end up in the bed. I want to pull out a few of the age-specific differences here, and this is all in your book for you to read. But children, remember, you're in your assessment class, you probably are going to learn, if you haven't already, about the different developmental stages. Okay, we kind of need to monitor that they're developing appropriately. They're crawling when they should. They're sitting when they should. And remember, with children, their extremities grow faster than their head, thorax, and spine. Their bones change in composition as they get a little bit older. And so they're more susceptible. Their bones are a little bit more fragile when they're younger. Their muscle size changes throughout the lifespan. As when we get older, there's certain age-specific changes that occur. We have a thinning of the vertebral disc, shortening of the spinal column, and then sometimes an onset of what they call kyphosis, which is a hunchback or humpback. Bone density gets lower, especially in females, and we're going to talk a little bit later on at another lecture about osteoporosis, because that's a big key thing in regards to women and the hip fractures. There's a huge correlation there. Cartilage becomes frailer as we get older, more brittle. We start to have loss of elasticity, and which all of this can lead in the older population to mobility reduction, reduced range of motion, pain in the joints, and reduced muscle strength, which, like I was saying just a few minutes ago, as we get older, that can lead to bone fractures. Okay? We need to, and it's funny that they didn't put a slide in here, but this is important, and this is, you're going to have to really, this is something that's going to follow you. It's looking at how mobility, follow you through nursing school. And whenever we're out there doing assessments, mobility is huge. Patients that become immobile have compromised body systems. And so when you look in your book, there's a chart in there that talks about the consequences of immobility. So with the cardiovascular system, you can have orthostatic hypotension, decreased cardiac output, which means decreased perfusion to the organs. Orthostatic hypotension is when the patient stands up, their blood pressure drops, and then you may see a patient that gets dizzy and kind of faint when that occurs. Venous stasis occurs from that reduced cardiac output, where basically the veins of the blood's not pumping as effectively. The blood is pulling, and therefore you end up with a blood clot or a deep vein thrombosis. With the respiratory system, what can occur is people lay in the bed too long. They're not expanding their lungs very well. Okay, this leads to atelectasis, which atelectasis, if you remember, is kind of a model of the lungs. The little grape-like structures are the alveoli, and those tend to collapse and can lead to pneumonia. Okay, so and all the secretions in the lung will pull as well. Musculoskeletal system, what we'll see with immobility is a decrease in the muscle mass and contractures and bone demineralization, which leads to bone fractures. Integumentary, of course, skin breakdown can occur. The gastrointestinal system will have decreased peristaltic movement and constipation. Okay, urinary system, renal calculi or kidneys, what we like to call renal stones or kidney stones. Urinary stasis occurs because we're not, let's face it, we go to the bathroom much easier when we're standing up. So, this can lead to an infection. Elements of the musculoskeletal system, you learning assessment in your assessment course. Now this becomes more of a focused assessment when we're looking at that system, especially when patients are having pain, reduced joint movement, reduced sensation falls, things like that. These are questions that we're going to ask our patients. And we also want to know about their medical history, their current medications they're on, lifestyle behaviors, etc. This goes along with our assessments to do a thorough job in assessing the patient's mobility status. There's common diagnostic tests, and again, these are in your book as far as the different types. If I were you, I just would write out X-ray and write this is for this. You don't have to write the whole paragraph, but be familiar with what each one of these types of diagnostic test is and what it takes a look at. Clinical management of patients with mobility issues. And you're going to see this term used where we use primary prevention and secondary prevention all the way throughout the curriculum. So with primary prevention, what we're trying to do is prevent patients or individuals from having mobility issues to begin with. So regular physical exercise, protection against injuries such as helmets, wearing seat belts, use of assistive devices, looking at stairs, to make sure that they're safe. And the older population will go in and look at carpets and lighting and different things like that to try to help with the clinical management of these patients and prevention. Optimal nutrition, how many fruits and vegetables, things like that. And we're going to talk more about nutrition in a future session that I'll be doing. And then looking at fall prevention measures. Again, that goes along with lighting and carpets, things like that I just discussed. Osteoporosis screening, I'm going to talk more about that. I've got a little bit more detail in another lecture, but it does ask the question here, what are the national guidelines for screening? So in your book, it talks about being 65 years old or older, or a young woman that has an increased risk for fractures. If osteoporosis runs in the family, you're going to learn that there's a certain body frame to patients that have osteoporosis. And this is our when we look at the screening portion, this is our secondary prevention. And then also with the national guidelines is a dual energy x-ray that looks at bone density, basically. And then at fall assessments, you're going to learn about multiple fall assessment screens that we use. Patients are screened when they come in the hospital, when they go in the nursing homes, to ensure that they are safe. General guidelines for collaborative interventions. We want to make sure patients that are immobilized, and this is for the patient that is immobilized, frequent turning and positioning and alignment to try to help prevent skin breakdown, looking and assessing the skin, assisting patients with range of motion, deep breathing so that they expand those airways and they don't have that alveoli collapse. Weight bearing, in other words, getting them out of bed, not allowing them to lay in the bed to eat, getting them up, moving, walking if the physician says we can. Measures to optimize elimination, such as sitting them up when they go to the bathroom, helping them to a bedside commode so they don't have urinary stasis. And nutrition, making sure that they're getting adequate amounts of fruits and vegetables, proteins, things like that that they need to help them heal and get stronger and have more energy. Other collaborative interventions, ambulation. Joint mobility, stretching, and balance are key to having that mobility health. Pharmacological agents that you may see prescribed. Anti-inflammatory agents such as NSAIDs, which is like ibuprofen, to assist with inflammation and pain. Because if they're in pain, they're not going to move or want to move around. They're going to have problems with mobility. Analgesics, we're looking at things like opioids or NSAIDs and aspirin combined. They also throw in muscle relaxers into that category because sometimes that's what people need in order to feel well enough to get up and move. Nutritional supplements, vitamin D is a big one. And this is one that we have to, when we give somebody calcium, we have to have vitamin D to assist with absorption. And they may also use things like biophosphates, which slow and stop the reabsorption of calcium. Okay. Surgical interventions, immobilization, and assistive devices. We're going to go into more depth on the some of the surgical interventions and the immobilization of the casting and the splints and things in another one of my lectures. In the lab, you've had or will have crutches, canes, walkers, wheelchairs. We didn't really talk too much about prosthesis, but that's when you have an artificial limb. We've discussed those things, and we'll discuss the rest a little bit later on. You need to pay attention, and we'll talk as we go through fractures and get into osteoporosis. You're going to see some of these things that occur more frequently in children versus more frequently in older adults, and we'll discuss that at more length in some of those lectures, and then we'll do some interactive things in class as well.